Good morning, everyone. And it's, oh, got to share my screen. Hold on. All right, are we in share mode?
Looks great.
Perfect, and everyone can hear me. Well, good morning, everyone, and I hope those gratitudes do their job, which was to help change our brain chemistry. So hopefully that worked. Today, I've been asked to come and share about the Early Childhood Mental Health Program, The Whole Child Matters at the Department of Mental Health and Addiction Services. Until around March of this year, I was the Early Childhood Mental Health Program lead with the department. And I am now the chief of the Bureau of Grants Administration. However, I still serve as a national SME in this space. So it's a pleasure to share what Ohio has done. I like to start off with this slide, this introductory slide, just to set the tone that the messages that we have for infant and early childhood mental health are very simple. The first and primary one deals with our attachment and attunement and is a resiliency factor across the lifespan. And while it is not rocket science, it is brain science, that when we communicate that you are loved, that builds the most important resiliency factors and protective factors in our human experience. So I always like to just start there and humble everyone to remember, to share, to express and embody the fact that we and you are loved. The other message that we know is critical right now during our COVID-19 pandemic pivot is that your mental health is just as important as your physical health. And we know that families and adults are co-regulators, and we use this particular image to help share that. And then finally, the idea that we are so focused on that primary caregiver and infant relationship, because it is here in the first year, in the first 5 years, that we set the trajectory for our child's development. I am going to leave time for questions, 2 minutes at the end. And if there's a chat room, please feel free to put your questions in there, and it's my pleasure to answer them. And if I cannot, I'm joined today by Grace Collisewell, who is the Bureau Chief of Children, Families, and Adolescents at the department. So when we say, what is infant and early childhood mental health consultation? In its simplest definition, infant and early childhood mental health consultation is a service that builds the capacity of the adults who care for young children. It is a capacity building service / intervention. Further, it's an evidence-informed approach. Oh, lost my slide, so sorry. I was just trying to move my little screen around so I can actually see my slide. Let's see if I can do that successfully. My apology, I'm driving, now you can tell. Evidence-informed multi-level mental health strategy that spans the continuum of care from promotion, prevention to intervention. And what we like to say, it's not about fixing kids, nor is it therapy. There is a distinction. It is a specialty. Mental health consultation equips, as we said, the teachers and caregivers to facilitate healthy social and emotional development in our young children. Ohio's program, since its inception, it was started off in 2013 by a governor's office initiative to address preschool expulsion. By 2016, with the resources and the work that we laid in as a state partnership, the Ohio program was written up and featured in the 2016 White House report, My Brother's Keeper. And most recently in 2019, our program has reached national attention through our partnership with Yale University, who just completed the second ever randomized control trial study looking at early childhood mental health consultation, and a particular tool that we are very excited about, the Child Tool, which looks at how we facilitate social and emotional development in children. And their randomized control trial study reinforced what we already know, which was good news for me as the program administrator. Certainly one of the surprises at that level is that this program works. This particular strategy and set of tools work. Whenever I'm talking about the program, I like you all just to have your takeaways. And for me, your takeaways will be to know that Ohio's infant early childhood mental health program is focused in 4 areas. I like to call it the 4 buckets. The first bucket is the a statewide Ohio partnership to prevent preschool expulsion. So we have a hotline stationed at Nationwide Children's Hospital in Columbus, but it operates as a statewide hotline where if a child is at risk of expulsion from a preschool, early learning, or family care setting, you can call the hotline and we will dispatch, I like to say, a warm body to that location to triage and intervene and start our work. So the first bucket of work is the hotline. And if you didn't know about it, I should do a survey, and I wish I could have put some bells and whistles on and done a survey, but that is critical to know. The second area that we are very engrossed in is what we call our workforce expansion. Right now, Ohio has approximately 120 credentialed early childhood mental health consultants working around the state. No other state has a workforce of that size, fully credentialed and located in our behavioral health agencies. We are only one of 2 states in the nation that has a centralized hotline. The third area, which was very important to me, bringing up this work, was to be able to say, what have we done? So we have a program evaluation component, which is supported by a statewide database. And that's very, very important piece of this work. And then finally, we have what we call a training institute, where we really refine our practices, and we have an ongoing suite of training. We also bring up train the trainers in our specialty area evidence-based practices. And that's very important for fidelity as well as quality. This is what our footprint looks like. If you were to go on to the Ohio Department of Mental Health website, we have this interactive map. If you hover over one of the color blocks, the affiliated agency's information will pop up. So this Northwest region is the Children's Resource Center. They would deploy a consultant to any of those counties who might have a child in need, and so on and so forth. So we have major color blocks. We have our 2 largest providers, our Hopewell Health Centers, covering our part of our Appalachian footprint. We have Nationwide Children covering our central Ohio footprint. That's 18 and 17 counties respectively. Another large provider is Stark, who County Mental Health. They contract out with numerous providers that covers that large footprint over to the Northeast. And then I skipped a little bit. We have a provider that covers our southwest quadrant of Appalachia and urban areas. And then we have the provider that covers the Northwest area, and then individual providers all along the way. So we have full statewide coverage, and we're so happy for that. We ground the work in our specialty in several logic models. We provide classroom-focused consultation. We provide child and family-focused consultation, and we provide programmatic level consultation. And our logic models take us, we develop these in conjunction with national experts and our local partners to really think through, what is this program designed to do? I take a pause to talk about good program design. I am considered one of the top program architects in the country, and it's important to design your programs with your outcomes in mind. When I was asked to design this program, the governor's office wanted a program to prevent expulsion. And I said, oh, we can do that. But if I only build a program that addresses expulsion, all we will do is run around the state putting out fire, addressing expulsion. If we build a program to promote social emotional development and wellness for all children, expulsion would become an outlier in our data set. So don't build your model for the problem, build your model for the larger cure, right? So we build a model that prevents fire as well as being able to effectively put fire out. And I'm just so proud of that. And I share that with you all because it's very, very important. Rather than we will address expulsion issues when a consultant is called from one of those areas, we go out, but what we assess is the classroom. So all children in that particular classroom in that setting benefit from our intervention. And that's what's important. We will address, and usually we find what's going on with the individual child, as we know with children and family systems, is often a result of that environmental interface. There are conditions going on at home and in the family, but those behaviors, that challenging behavior that child is using, is evidenced in that classroom primarily. And so that's what we're able to intervene on. We achieved our short-term outcomes early in our process, and now we're really looking at our long-term outcomes and getting ready to go back in and take another slice of them. So our logic models are across all areas of our service delivery, and ultimately we're trying to support our partners in education. We know that when children enter kindergarten ready to read, that they achieve that third grade reading guarantee, and that third grade reading guarantee is the indicator for how they're going to do across their educational K through 12 experience. So that's why we're so focused on that area. Obviously, we're reducing our expulsions. School readiness and performance is where it's at. Digging now into these stable family units. Of course, COVID really impacted that. Always building positive behaviors and skills that are maintained, keyword maintained, not just achieved, but maintained. And academic outcomes are so important. And then our training. If I get a chance to come back, Dr. Boyer will talk about the program evaluation and really pull the curtain back on what we were able to do with all of the beautiful models. But again, we want comprehensive and qualified workforce. We want to make sure that that training is supporting the outcomes that we talked about across the other logic models. And so that's our focus. I think I touched on these already. So we know that it works. The short-term outcomes that we see is that we have changes in teacher attitudes and beliefs and knowledge and self-efficacy. We do see decreases in teacher stress, decreases in those problem behaviors, and we see improvements in interactions with our children and family. And this is supported through our program evaluation. Long-term improved school readiness, reducing that staff turnover, improving the classroom environments. And as I mentioned, sustaining those positive behaviors are critical. I want to add one more piece of research into our conversation, and that's from Yale, where Dr. Walter Gilliam was the first researcher that talked about the preschool expulsion problem. What we now know, based on some of his subsequent studies, is that when a teacher, we have a predictive model for preschool expulsion. I love science. When we find teachers or caregivers in the early learning settings that are high on depression, high on teacher stress, they are more likely to request removal from the classroom of a child. We know that expulsion is not a child behavior problem. It is an adult decision problem, or we like to say issue. So that is why it is so important that we construct our intervention to work with the attitudes, the belief, the implicit and explicit biases and stresses of our caregivers. They are direct, and that kind of translates into treatment. That is a direct correlation to what's happening with children's outcomes. Now, in came COVID-19. Oh my goodness. The one thing I want to say about this pandemic is that it has certainly changed the face of our human footprint across the planet. We have a once in a lifetime shared experience with every other human being on the planet at this time. That is profound. COVID has been a major disruptor and dysregulator of every aspect of our human experience. In some cases, giving us positive outcomes in terms of our environmental footprint, our family connectedness, and ushering in technology in a manner which we may not have seen before, but has certainly come at a price. So with COVID-19, we did an immediate field study to find out what pivots people were using, and we are promoting technology to stay connected. We shifted to online training platforms for all of our professional development and training. We also had to incorporate supervision and model fidelity in a remote environment. We were flexible with our data collection and our service units. It is done electronically, but we understood that those were fluctuating due to COVID and the closure of many environments. At the department, it was critical for us to guarantee funding and carryover funding models, and that we knew that behavioral health is deemed an essential service, which drove system-wide technology upgrades to move into the telehealth and telemedicine environments. We also stood up incredible partnerships with Job and Family, DODD and ODH to offer mental health support to the child care staff, the residential staff who are still on the front line, and other frontline responders and medical staff. We also did a wonderful body of work with advocacy organizations and think tanks like Ohio Groundworks to offer family supports. And we worked with private and public education, ODE, local jurisdictions, as well as the Catholic diocese to develop return to school mental health strategies and build and understand what the hybrid considerations were going to be. And most importantly, to pull out and tee up the social and emotional effects of the pandemic and the isolation, depression, isolation, the increases in cyberbullying, the increases in suicidality, and the increases in substance use and abuse, as well as interpersonal violence. We're seeing spikes in all of those areas. And of course, during all of this, the opioid overdose epidemic surging. What I hope for now is this period of resiliency and hope. We have entered new conversations regarding self-care and dealing with the accumulative stress that we're all experiencing, and our clients, that accumulative stress from loss of income and housing and food, so what we call food insecurity, the rates of infection, literal grief loss, and the political pressures and our business sector pushing us to return to a new normal, but all the while we needing to manage and mitigate risk. We are supporting the communities and first responders and parents and employers. And again, keeping most of our catalog of training into an online environment. Our service delivery is now addressing our remote models for reflective supervision through communities of practice and learners. We stood up a trauma training certificate, as well as an infant mental health transdisciplinary credential. And we understand that in terms of service delivery, we're seeing both an in-person, a hybrid model, in-person and a virtual model for training and services. This is a sample of the COVID-19 toolkit that we developed with Ohio Groundworks. We will make that available through the resources on the link. We want you to share these with your communities. It's an electronic toolkit, and it's built on the top 10 tips for parenting that we developed in conjunction with Dr. Acton in the governor's office early in the pandemic. So what's next? I like to say it like this, keep gratitude at the forefront. The science says that regulatory experience for gratitude is building our resiliency. We are going to keep our COVID-19 strategies in place, continuing our pivots, but managing stress and risk. It's helping us to look at new strategies to deliver in our models of classroom, child, and center-based consultation, and expanding our footprint into the community more now. We are expanding our partnerships. We are now not only providing consultation to all 88 EI teams, we're providing early childhood mental health consultation now to all 16 state support team regions. And those are important partnerships because everyone's seeing the behavioral health surge. I just like to remind us that we are in a moment of service. You're serving in an incredible moment in time. We want to say thank you for that, but this has left an indelible mark on humanity, and to not minimize that. And I ask us and invite us all to imagine the possibilities of what this experience can do for us and embrace technology in healthy, right, and productive ways. For more information, please get a hold of Grace Colasul or Lisa Golden, who's attending another meeting today, the new Infant Mental Health Project Lead for the department. I am still at the department as our grants chief and administrator, but again, you can contact any of us if you have any questions. Hopefully I've left a couple of minutes for any questions. And Bobby, anybody in your team monitoring the chat box?